So as we start our discussion, I want us to focus on why we're here. It's our patients. That's what this is all about. And two patients come to mind when I think of this. When I first started practice 20 years ago in Central Texas, I cared for a well-respected elementary school principal whose intermittent hydrocodone use for kidney stones slowly increased over the years to where my nurse, who used to work for him, said, he's sending me flowers every week. I think something's up. He had become addicted to the hydrocodone. The second example I think of is a young man brought into my office 2 years ago who overdosed on synthetic fentanyl just a few miles from the state capitol. And as we finished that first visit, his mother looked me in the eyes and said, he was an Eagle Scout. And when I told this story to Representative Sheffield, he just sighed and said, Eagle Scout, drug addict. That's when I know that we have a problem. So we'll go through our slides here, but I want to paint broad strokes. We've worked on this for several sessions. We've worked hard to develop coherent policy. We think we have a good start, but there is room to improve. So the first topic I'll start with, as you see the different bills up here, is the prescription monitoring program. We use it. It's improved considerably since it was run by the DPS. The Board of Pharmacy has taken it over and made it a much more efficient product. As you know, a mandate for us to query the prescription monitoring program with every prescription for certain controlled substances, mostly opiates, some barbiturates, some benzodiazepines, and crisaprotol, was passed. We were able to delay that mandate from this September to next March because we know a lot of doctors are compliant, a lot of us have the tools, but we need a little more time, and we appreciate the legislature listening to us on that. We also were able to secure additional funding to make the prescription monitoring program more efficient. If you've used it recently, you've noticed a feature called Narcs Care. So it helps score the patient's risk of stimulant misuse. We had funding to cover the user licenses for all physicians and pharmacies, so we don't have to pay that out of our practices. So we were able to block a tax on us to do our jobs. And we are continually pushing the EHR vendors to incorporate these features directly into their EHR. Having had that feature for 6 months now, it is frankly amazing. In our practice, we're all using it even without the mandate. I clocked myself yesterday, took 12 seconds. I use it to check ADHD med doses on my new teenage patients when they can't remember how much Vyvanse they took. I use it to double check the patients who've been in the ER and come see me, the patients who've just been in the operating room. When it's fast and efficient, everyone in my group is using it without a mandate to provide better care for our patients. And it's powerful when you can turn the screen around and say, look, here's what it says. You went to someone else a week ago. We got to have a discussion about this. The second broad issue is electronic prescribing of controlled substances. Basically, this is coming. Medicare is mandating it to take effect in 2021. The state was going to mandate it earlier. We were able to persuade them to change their deadline to coincide with the Medicare deadline. So in January 2021, you will need to electronically prescribe controlled substances. Could everyone who's doing that currently raise their hands? So I love it. It's the greatest thing since sliced bread. I can count how many handwritten scripts I've written in the last year. It's easier for me. It's more efficient. It's trackable. Scripts don't get lost, and my DA doesn't get stolen. I've been in practice here in this state for 20 years, and within 2 months moving back into the greater Houston area, my DA had been stolen and was being used all over North Harris County, Montgomery County. So it's not perfect. I heard a comment from the crowd, but I think it does bring greater security. We also were able to secure additional funding for medically assisted treatment, because none of this matters if we're just policing patients, if we're not trying to help them. And Dr. Bruggeman will speak much more about that. But from talking to family medicine colleagues, MAT works. MAT can help people, and I've got some patients getting it now. It's a much different experience to talk to them openly about their pain and know they're trying to improve their addiction. An area where we can improve is the CME requirements. We've discussed this with the legislature. We have said most doctors get CME on this topic. We have said there's not any research showing that mandatory CME improves practice of prescribing opioids. But we have mandates, so we have to live with that. We have 3 different bills sponsored by a representative we work well with, 2 of them from physicians. The biggest issue we have is to reconcile them. And you'll see some different requirements here in the bills from Dr. Zerwas, and then from Dr. Sheffield and Dr. Price. And here you can see the issues. So is it 1 hour as CME? Is it 2 hours? Is it once? Is it every licensing cycle? Your TMA staff know this is a problem. They're well aware of this. The Texas Medical Board knows that this is a problem. And they are convening a stakeholder meeting in a month to address these issues and reconcile these 3 different bills through the rulemaking process to create coherent guidelines for us. Your TMA also provides CME on opioid use that will be enhanced to meet the requirements once the medical board issues their consensus rules. And if you have TMLT insurance, I did my 4 hours yesterday. That gets me my TMLT insurance discount. I did mine on opioids because I knew what was coming. So there are some good resources out there, and I do think we learned something from it. I do simply disagree that a mandate is the way to go. But we will work with the legislature and the board on that. Final issue is acute pain. And this is one issue that needs a whole lot of definition and a whole lot of work. You may now prescribe opioids for no more than 10 days for acute pain. So when I was asked questions about this, I thought, well, what is 10 days? Is that 1 Tylenol number 3 a day for 10 days? Is that 2 oxycodone 10 milligrams every 4 hours for 10 days? You can see the problem. What's acute pain? Even though this hasn't taken effect, I've already had one payer, Blue Cross Blue Shield of Texas, kick out 2 prescriptions on chronic pain patients of mine on whom I was simply changing the opioid from one to another as part of their comprehensive pain management program involving therapy, NSAIDs, various other methods, as an acute pain prescription. I have no way of telling them that's not acute pain outside of calling them and telling them, and they say, no, it's not chronic, it's acute. The prescription gets kicked out and modified. So we have work to do there, and we will be doing work, 1 with the medical board, and 2 with payers, I'm sure, going forward. To reiterate what I've said before, this is the key, as those of you who worked on legislation before know. Big first step is passing the legislation. The even bigger second step is making sure the rules reflect the intent of the legislation. So as we go forward, we'll be working in October and going on down the road on let's reconcile these CME requirements in a system that works for us so that TMA knows what's due for you and you know what education you need. Can we get credit for people like me who did their CME yesterday or you did it last week or last year? Can we get that accounted for? Can we clarify what acute pain means? Is it post-op pain? Is it a new pain? Is it a change of prescription on existing chronic pain? There's obviously a lot we have to work out. So stay tuned. More to come. And please write down your question on this. I'm happy to address those at the end. And now I'll hand it off to Dr. Botsford.
All right, good morning. So now we've heard what we've been told to do by the legislature. I want to spend a few minutes talking about what should we do, what's right for patients, what is following national guidelines, best practices for the care of our patients who do need treatment of chronic pain or other disorders. So whenever we think about what should we do, I think it's helpful to look at a little bit of the why. If you're in a group with other physicians, it's really hard to just throw a policy out and say you got to do it because I say so. So these are some of the motivators for why it's the right thing to do. So when we look about drug misuse in Texas, prescription pain relievers outrank all the other causes of illicit drug use, which is pretty shocking. And when you're looking at even high school students, so 15% have used a prescription for pain medicine without a prescription. So that's diversion of someone else's pain medication, whether that be a family member, a friend. In Texas in specific, the death rates just continue to go up. And what you'll see here is kind of in the middle there, when we look at benzodiazepines and when we look at prescription pain relievers, they're pretty closely matched as one of the biggest causes of death. So we probably should not be using benzodiazepines to treat chronic pain, but there are patients who continue to be on it for other reasons. And so that's often why they get lumped together as when you're thinking about controlled substance contracts, pain management contracts, one of the reasons we think about the two together. They are a significant cause of morbidity in Texas. So not all deaths are a cause of physicians overprescribing. There are situations where it starts off in a good relationship and what we think about as acceptable use relationship, and then it evolves from there. There are people who die in what is considered acceptable use. That's often from unanticipated comorbidities or things that just happen. But the categories where we do have a chance to make an impact are especially in the aberrant behavior and then certainly in the abuse and addiction. And so when we think about what we have an opportunity to do in our offices, it's getting those 40% that are not acceptably using these medications and trying to tackle that. Overprescribing has been mandated a little bit for us, although that's still incumbent upon us to think about the lowest possible dose and quantity to help treat pain. So I'm going to actually start first on developing an office procedure and not go into a pain contract. A pain contract by itself is not going to fix your problem. I think if you're not already doing it, developing an office procedure, and I say procedure because it's less scary sounding than a policy, but a standard way your office handles this. And this can apply for someone who's in solo practice, making sure that everyone on your staff understands how you handle it in your office, but it becomes especially relevant if you're in a practice with any more than just yourself. Because when patients find variation among prescribers that is used, abused, and taken advantage of, sometimes innocently and sometimes not. So if you are in a practice where you're a decision maker or where you can convene the other people in your practice, having a conversation first about what triggers an agreement is a great place to start. So what medications are you going to require a pain management agreement for? What classes of medications? And then what do you define as chronic? So some people will use more than 6 weeks. You could make an argument that after 4 to 5 days, which I think Dr. Bruggeman will hit on a little bit later, that's really when that risk of misuse and addiction increases. Whatever you decide, stick with it and make sure that everyone's on board with using the same thing. It's also helpful to outline whether medications will be prescribed on a first visit. Many offices have taken a strategy of not doing that at the first visit to cut down on doctor shopping or someone that's looking to just come in for a single visit, get their refill, and not be part of an ongoing prescribing relationship. There are some situations where that may be appropriate, but whatever you decide, make sure everyone in your office is on the same page on it. You want to think about how refill requests and exceptions are handled. Standard of care usually is that if anything's an exception, that's something that gets talked about in person, not handled via a phone call or an excuse about a misplaced prescription, a dog eating a bottle, things like that. You want to really spend some attention on how you're going to handle if you're not there. And there are times for all of us when we are not there for our patients and someone else has to help cover for us, or you're handling it from afar. Creating standards for urine drug monitoring, talking about weaning policies for patients when they get violations. These are just some of the talking points to go through. And less important is exactly what you decide, but that consistency is hugely important. So once you've had that conversation with your group or in your practice, or if you're the sole decision maker, reviewing best practices, then I think it's important to transition to developing your controlled substance agreement. That tends to be the language that's considered your preferred language as opposed to calling a pain contract, but controlled substance agreement, because this should handle more than just chronic opioids. You're also looking at benzodiazepines or those other medications that are considered high risk. These are the things that should be in it. Some of the older versions of controlled substance agreements, and there's boilerplate versions you can use, they're very legalese. There's a couple new resources that I would point you to. So Cleveland Clinic Journal of Medicine had a great example of one that looks more like a checklist, but trying to shoot for something that has a 6th grade reading level and is something the patient understands makes it more valuable. So there's very little evidence that a controlled substance agreement improves outcomes. I can't stand up here and tell you that. What I can say, though, is it is considered the best practice to do it, and you have an opportunity to make it a valuable conversation with the patient. And you can do that by making it not look like a legal document. A shocking number of patients who get asked if they ever signed an agreement, when they did, report that they never signed anything. Even if you have the written copy there, because again, these used to be used just as looking like a legal document, not the process of informed consent that we all think of as a best practice. So if you're in a practice where you don't have anything outlined for how you handle it, and when I say outlined, I would put it on paper, not just keep it in your head or use it at a staff meeting. Think about allowing plenty of time to let your patients know about it. If you haven't been doing this, this can be very disruptive, and for patients on a chronic medication, it's very scary to think there might be a change. So make sure you allow enough time to inform your patients and educate them on the why. You can send medications, post on your website, whatever you're going to do. I would discourage letting the patient show up for their visit and find out that way. We found it incredibly helpful to spend time on educating our staff as to some of the language they use with patients, as well as the why behind it. Before we did that, we heard many people just saying, well, we have a new policy. And that didn't resonate with a lot of patients as to explaining the why behind it. It comes from a good place, and spending some time on the why is important. Think about how you're going to handle urine drug screens. So that is a pretty standard part of any prescribing relationship of high-risk medications, to make sure you're not having patients take things they shouldn't be, or misuse or not use what you're giving them. Urine drug screens done in a lab can be insanely expensive for patients if you don't have a conversation with your lab vendor ahead of time. We're talking $800 to $1,000, much less if you're doing confirmatory testing. If you have a positive, we can get into the $3,000, $4,000 very quickly. Point of care urine drug screens are often a great cost-effective way to go. They can be done for less than $5 in the office. Now, you still potentially need confirmatory testing down the road, but get with your lab vendor to figure out what the cost is, what coding you need to use to get it covered. And then when you're working with this population, if you're not waivered to do medication-assisted therapy, make sure you have resources in your community. Because as you start to look at these patients more closely, you're going to find people who continuing to prescribe is not the answer, because you're picking up on situations where they need treatment for their addiction. That may not be you, but if it's not, figure out who you're going to use in your community. And I know I see some pain management physicians out there. If the response to all of this legislation should not just be, I'm going to cut off and I'm just going to stop prescribing. That's a disservice to our patients. And I think our pain management colleagues would say, don't just refer to them and expect them to have that conversation with them. If your intuition is telling you shouldn't be prescribing, we encourage you to have that conversation with the patient first. There are some patients who maybe need a little bit more time to get around this, so think about always meeting the patient where they are in terms of potentially prescribing a bit longer, under close monitoring, while you figure out a plan for them. So we talked a little bit about education of physicians and your practice managers. They're the ones that are going to deal with patient complaints when you start implementation of something like this, and empowering them to understand the why is helpful. Shared group prescribing practices, if you are in a practice with more than one physician. 28-day prescriptions is a common strategy to decrease the chance that you're going to get a refill request on a weekend. So if you prescribe these medications for 28 days at a time, that's always going to run out on the same day you prescribed it. So theoretically, you shouldn't be getting an emergency call on a night or weekend, or you can feel less guilty if you get it, because it probably means there was variation in how you prescribe, they're taking that prescribed medication. So utilizing standard checklists, there's not one that's considered the best, but when you're documenting on these patients, you want to show functional status, you want to assess it, whatever way you look how. These are some of the ones we use. And then electronic prescribing has been mentioned, certainly a way to decrease diversion or someone using your DEA number. If you haven't already worked with your EMR vendor to try to get that PMP button integrated, there is a cost to it for most vendors, but it saves time dramatically. I mean, from 3 to 4 minutes to do it to 12 seconds is very fast, but nonetheless impressive. All right, those are just some resources. We don't have enough time to go through all of it, but the AAFP does have a chronic pain management toolkit. The AMA has some resources from their opioid task force on how you can get help for patients, as well as educational materials for physicians if you want to share it. It is more specific to opioids as opposed to, stimulants or benzodiazepines, but some of the same things apply. And American Academy of Pain Medicine has a good adaptable template if you are starting from scratch in terms of creating a patient agreement and need a place to go.
Thank you. I'm going to cover some similar concepts here, and then want to leave some time for questions, comments, because the practical nature of implementing these things that sound great on paper that's the hard part. So I think there's a few things, just as Dr. Botsford just mentioned, you have to understand why you're doing what you're doing. You can't just do something. And so why do we have a legislative push? Why do the people who were just up here in the last panel talk about some sort of CME? Why are they talking about putting restrictions on how long we can write for acute opiates? And the answer lies in this study that was done. And as in many things in medicine, one study can dramatically change everything. Think about the 38 patients that were studied by one doctor and found to not have any evidence of addiction to opiates, which was the cornerstone of the marketing efforts by Purdue Pharmaceutical that led to the marketing efforts and the prescribing practices we have in the United States that led to 170 people dying every day of opiates. So one study can be very powerful, and this one study is the study that's passed around the country. The bottom describes the number of days that a patient is given a pain medication, and this only applies to the very first prescription. The left-hand side tells you how long the patient is on the medications long-term. In other words, what's the percentage chance that the patient will still be taking narcotics? You see two lines, one that's 1 year and one that's 3 years. And what I'll point out is that when you hit the 5-day to 6-day mark, there's an inflection point in the graph, and the graph begins to tick upwards. So the concept is if we can reduce the number of prescription pills being given to the patient on the very first prescription. Now, I recognize that may not be how the legislation was written, but this is where it all starts. If we can shut it down on the very first prescription, we can reduce the number of people that are on long-term narcotics at 3 years to about 5%, and at 1 year to about 10%. If we allow traditional prescribing habits to prevail, which is, I'm not going to see you for another 30 days, so I'm going to give you 30 days worth of tablets. Take this tramadol. By the way, tramadol is an opiate. Take this tramadol 3 times a day, 90 tablets, come see me in a month, and let's see how things are going. That's standard traditional medical practice. If you practice that when this study was done, the chances of the patient still being on that tramadol at 3 years is over 20%. And the chances of that patient still being on it at beyond a year is over 40%. So you can see if you're responsible for everybody that's involved in the Texas plans that the state of Texas pays for, whether you're a teacher or a retired employee or on Medicaid, we're very interested in trying to reduce the number of people that are on narcotics long term. I can go on for hours on what the costs of care are when that happens, and the numbers extrapolate. So we all talk about the number of people who died, and the number goes up every year, and whether or not that's related to prescriptions, or that's related to fentanyl, or that's related to heroin, or that's related to China, or that's related to Mexico, or that's related to American policies. But at the end of the day, people are dying. And when people die, it's a big deal when they can fill an entire NFL stadium with deaths related to opiates. So the sobering reality is this is not a small number of people. But unfortunately, the sobering reality gets even more real when you start talking about the people who misuse your opiates that you write. So for every person who died, for every NFL stadium that's filled every year, 10 people are admitted for abuse, 32 people go to an emergency room, 130 people become abused or become addicted, and 825 people become non-medical users. That's 825 NFL stadiums filled around the country with people who don't use medications the way they're intended or prescribed. So what do we need to watch out for if we're prescribing narcotics? And I agree with a lot of the things that have been said already. I think you should understand as a good base point that our Texas Medical Board has come out with some concerns that they had, largely about pain management clinics that were not being registered as pain management clinics, but this applies to all people who practice medicine in the state of Texas. They've decided that we should have the ability to inspect a practice if you're prescribing over one patient outside your geographic area. So if people are coming and seeing you from long distances away for the purposes of asking for narcotics, that should be a red flag, okay? I'm not saying good or bad about the Texas Medical Board rules. What I'm saying is these things are things that we need to be watching out for. There's a reason there's a rule that's been written. If you have multiple patients within the same family or at the same address that are being treated for chronic pain, so if it's a husband and wife, if it's a child and parent who still lives at home, if it's two people who are just roommates, why is it that these number of people at this one address all want narcotics? Is there something else going on? Again, this doesn't mean stop writing, it means ask questions. If you're one of the top 50 prescribers in the state at any time in the preceding 12 months for prescriptions of opiates, benzos, barbiturates, or soma, excluding prescribers at certified pain management clinics, those treating cancer, or those in hospice, okay? I don't know how you get that information, but if you think you're in that list, you may want to ask around and find out. If you're prescribing to multiple patients opiates in combination with one or all of the following: benzos, barbiturates, or carisoprodol, which is soma, in a clinic or facility. I'm going to get to some points about that, but please recognize that if there are two people writing for a drug, one writing for the benzo, one writing for the opiate, and they're written in combination with each other, both of you are responsible. Both of you, not one. And I know doctors who have come to me and talked to me about something that they've been pulled in front of the medical board for and ultimately sanctioned for not checking the PMP and not understanding what was going on with their patients when they were co-writing drugs and another doctor in their community was writing other drugs. So please, please look before you write any of these medications. And then, of course, any sort of complaints related to inappropriate prescribing practices, including to law enforcement agencies, healthcare regulations, etc., can ultimately trigger an investigation. Now, inspecting your clinic doesn't mean you've done anything wrong. It just means that it's open to inspection. And again, if the Texas Medical Board has deemed that these things are important, these are things that we should think about when we're going to implement this into our practices. So, check the PMP before writing any pain medication, before writing the second script, the third script, the fourth script. It doesn't matter. Patients go and see other doctors and forget to tell you about other prescriptions they're taking. Benzodiazepines in combination with pain medications are a dangerous combination. That's been proven through many studies. It's been proven with all the celebrities we know that have died recently. If the patient has a pain management physician prescribing for chronic pain, please do not write for a benzodiazepine. I don't care if it's for anxiety or anything else, because this will throw off everything that pain management doctor is doing. You need to communicate within the community. And I know we're all busy, but writing for those drugs puts both you and the other doctor at risk for not taking care of this patient appropriately. And in addition, for putting the patient at risk. They may have been teetering on the edge of stability with that pain medication, and the benzodiazepine they take at night for their anxiety or to help them sleep or whatever else for the reason that it's being written ultimately tips them into respiratory distress. If you aren't already doing so, as you've heard from all three of us now, please begin implementing electronic prescribing for controlled substances. It eliminates a whole lot of issues with regards to patients saying the script was lost, I don't know what's going on, getting your DEA license stolen, all sorts of things. If you're going to write for pain medications on a chronic basis, you must follow the state regulations. We've just talked about them. New ones have come out. There are discussions. It's in the Texas Medical Board, in the TAC. If you guys want to read about it, that talks about if you're going to write for chronic pain, there are some things you have to do, including having an agreement with the patients. Sign up for the PMP, but don't forget to add your staff members. If it's a lot of burden for you personally, that doesn't mean that your staff members can't look up, print out, put it in front of you, put it on the chart if you're still using hard charts, put it on the wall or wherever it is that you guys communicate with the staff as to what's going on with that patient. Print it out, have it there ready for you to review so that you're not taking time in your clinic to see the patients. Chronic pain, we discussed what is chronic pain. Is it 6 weeks? Is it 10 weeks? Is it 2 days? Is it 5 days? The answer is it depends. Chronic pain is defined as pain that goes beyond an expected time period for a given problem or injury. That's straight from our laws and regulations, okay? I didn't make that definition up. So, I'm orthopedic. So what's chronic pain after an ankle injury, after an ankle sprain where they go to the ER? I don't know, it might be 5 days. But what if they got their ankle fixed? Well, that might be 6 weeks. So chronic pain is going to be very difficult because now we have this definition of acute pain that has a 10-day restriction and chronic pain that doesn't have a 10-day restriction. So this is going to be where the rubber meets the road, and we're going to have conversations with our pharmacists, with our insurance companies, trying to sort through all of this. But please understand what chronic pain is and when you fall into chronic pain, and therefore when you need to follow the rules and regulations that relate to writing for patients who have chronic pain. Always perform a thorough history, including other pain management attempts and treatments. Document your thought process. If the patient tested negative for something, write why you decided to still writing for the narcotics. If they tested positive for an illicit substance, whether it's marijuana or something else, write why you decided to still continue. I counseled them. We talked about it, what have you. Have a treatment plan and update it, okay? It's not just we're keeping them on narcotics in perpetuity. I have a treatment plan. I talked to them about it. It's our 3-month discussion about why they're still on narcotics. Could we reduce? Have an informed consent process. Discuss the risks and benefits with the patient, no different than a surgery. Have a pain management contract. Confirm adherence with urine drug testing, how often that is, how that's done, whether it gets confirmed is up to each of you in your individual offices. It can be difficult to figure that out, and I'm happy to answer questions about that. And then don't be afraid to ask for help. You have to know what your resources are in your community. You have to know when to say, I can't handle this patient anymore, or when it's a problem. All right, with that, I'm going to sit down, and I think we want to answer any questions you have about implementing.
So thanks, Dr. Bruggeman and Dr. Botsford. So our first question, Dr. Bruggeman, one for you. How does a physician become certified as a medically assisted treatment provider?
So medication-assisted treatment, MAT programs, involve really 3 drugs, right? The Vivitrol, which is the depot form of the naltrexone. You've got the Suboxone or buprenorphine drugs, and then methadone. Methadone's its own world. That has to be done in a methadone clinic. If you want to become an M80 doctor, you need to take the 8-hour CME course. It's free. You can go on the SAMHSA website nationally. I think we probably have some Texas resources that will also click you into an 8-hour course. You take the 8-hour course on Suboxone and prescribing and how to handle these patients. At that point in time, you have to file with the FDA, with the DEA, that states that you have now completed this 8-hour course. When you've completed the 8-hour course, they will then give you a special DEA license number for when you're writing for narcotics for the purposes of addiction. If you are utilizing Suboxone or methadone for the purposes of chronic pain, that's a whole different story. It does not fall underneath the MAT guidelines. But if you want to be an MAT doctor, it's 2 steps. CME, apply with the DEA, get your special license, and now you can do it. Then there are restrictions on the number of patients you can treat in the first year and second years, and ultimately the third year, and ultimately ends at 275 patients.
So I'll just add, there is an initiative in Texas to get people waivered. So if you go to getwaiveredtexas.com, there's resources about the training, about bringing a training to a site near you or ones that might be happening. It's really pretty painless. Taking the waiver training does not teach you everything you need to know about MAT. Wouldn't delude yourself in that sense, but it's a great complement to the treatment of chronic pain because you're going to find people who really need MAT instead. So if you don't do it, definitely find someone who can do it in your community. If you're also worried about, hey, well, what if I get my waiver and everyone gets the word that I'm the place to go for MAT? You can choose to be listed or unlisted in the directory. So if you want to do it to take care of your own patients, you can still do it within your practice without necessarily becoming a magnet. That's up to you.
I get 1 inquiry a year through the website by being listed as having a waiver. So I would not concern yourself whether or not you're going to get bombarded.
Yeah. So I've got the signal for time, so we'll do one more question. I know at least Kelsey Siebold in Houston has several MAT certified doctors. So some groups are looking at having 1 or 2 people within the large group get this training. So the question is, will there be a discussion of new opioid prescriptions for chronic pain while the agreed dose or the previous dose is being decreased or tapered to avoid the acute pain issue? So there certainly will be when we meet with the Texas Medical Board. That to me is the number one issue facing my practice, and when I've already hit with payers rejecting prescriptions when I'm transitioning patients. So I appreciate the question. To me, that's a key issue that has to be clarified. If I'm tapering patients, I have patients addicted to tramadol that I'm tapering down. I'm transitioning to a less potent opioid. So I agree that's a key issue, and we definitely will bring that up in October. I'll ask the other panelists their thoughts on that.
Yeah, this is all still new to all of us. We're still trying to learn how to implement this. Everybody's going to be on guard. The pharmacist is going to be on guard. The insurance company is going to be on guard. They want to follow the rules and regulations to a T. And I think some of this will calm down, but certainly guidance at the meeting in October will help provide some framework for everybody to work from.
All right. So that is our time signal. I'll throw in one last question that I have to throw in. So how do you think marijuana legislation would affect opioid use? Should this be considered in Texas? Shocking, we get a pot question. I don't know what will happen with marijuana. I don't know what will happen with the THC or hemp-based products. I know that when I have 80 and 85 and 90-year-olds asking me about CBD oil, bringing in the bottles, and saying they got their edibles from the brother in Ohio, we've got to have this discussion, and we've got to have these discussions with our legislators and policymakers. So thank you very much for your time and attention. Thank you, my panelists.